you, ma'am, for giving this opportunity. So as a part of routine clinical services like TDM services, so we come across this case. So here I will be presenting a case like a 16-year-old female, KR, who was diagnosed as chronic kidney disease, stage 5. So with the primary cause of congenital anomaly of urinary tract and kidney. So undergone living later renal transplant, that is allograft. The donor was father. The induction regimen we have used is ATG 50, and also tacrolimus was started as 6 milligram per day. So here you can see the post-operative days and tacrolimus dose and whole blood tacrolimus concentration. Even though we are giving adequate dose like 6 milligram BD, but we are not achieving the therapeutic range. So what is the clinical issue is initial post-operative period, the tacrolimus therapeutic window was not achieved despite giving high dose. So we planned a pharmacogenetic and pharmacokinetic analysis. The pharmacokinetic analysis is dose exposure response. So we have analyzed. So for this we have taken a written informed consent from the patient. So we did some special investigations like genotyping. For genotyping, initially we did like genomic extraction, that is DNA extraction by using the kit, and then genotype came as CYP3A5 *1 mutation, that is homozygous pattern. So here you can see that is SNP CYP3 *1. So see here you can see this we did like to explore the dose exposure response or analysis. So C0, C1.5 and C6. So the dose which was given here, it is 7.5 milligram BD in the POD of 65 days. Coming to below panel, here it is, we have given 4.25 milligram, like almost same dose, but it given us TDS, that is thrice a day. Why we have did like this? So in C1.5 we have high therapeutic range like this 37.88, but in C whenever we are giving 4.25 thrice a day, we have 25. So the thing is, these results suggest that the peak concentration achieved here, it is toxic range, and also the concentration at 6 is also high. So the suggested, we have planned for a scale dosing reduction, that is from 7.5 milligram BD to 4.25 milligram TD. The lessons learned we have from these cases, individualized dosing by using by doing the genotyping, and also the based upon the PK profile, so we have given TAD dosing. So this will possibly reduce the long-term CNA toxicity and also will improve the better clinical outcome and the graft outcome. Thank you.
Thank you, Kumar. Actually, Kumar actually did a lot of work in this patient's dose optimization. So I would he just missed a little bit. So look at the peak there, that is when we were prescribing 8 mg BD, so 37.88. It's 37.88, which is way high of when we know that beyond 20 it is going to be nephrotoxic. So we could by TDS dosing we could bring it down to 25, and that actually increases the pill burden on the patient, but somehow increased pill with a better long-term outcome. So all I wanted to highlight is regimen optimization, keeping in view your long-term goals. Thank you. Yeah, Dr. Sumit. Yeah, please.
Thanks a lot, Dr. Smita, and your place. I will thank you at the end, all of you. Maybe I will start my presentation soon. Thanks a lot anyway for inviting me, and all the previous speakers, Dr. Sandhya and Dr. Smita, has actually gave a good overview about TDM so that I don't have to spend time talking about that TDM, how it is important for the patients. Here, my major area of work in the department is antimicrobial agents, TDM of antimicrobial agents. I can give you evidences on how it helped patients. What are the possible study mechanisms where you can actually prove that TDM works, etc. So to start with, sepsis. Sepsis is a threat to life, especially for particularly patients, and it's common in ICU patients around.
We're establishing a service. At the end of the day, the outcome studies are completely lacking. A group where TDM was not done, a group where TDM was done.
Correct.
These kind of studies are unfortunately lacking from most of the parts of the world, even in the developed countries. And making an RCT work in a TDM setting is almost impossible.
Maybe you wouldn't have to do an RCT per se. Maybe a simple observational or you could follow the same.
So when let me know when there is evolving evidence which suggests that TDM is beneficial. How will you not do it, even for an immunosuppressant drug? It would be disastrous not to offer a TDM, not assessing tacrolimus level in an organ transplant patient. So I'm really looking forward to an answer. How will you conduct those kind of studies where you would say that you would not do TDM versus you have done TDM, and what is the result?
Yeah. Good point. I mean, even I don't have an answer. But
No, we all need to find an answer for this. I mean, how will you design such a study? You're very right that you should have observational data, but we would like to have an historical data set where when TDM was not practiced. And if you have an data set, the clinical practice has changed so much. The surgical technique has changed so much. Even for the hematopoietic stem cell transplant, things have evolved over a long period. decades.
Yeah.
So we really need to find a design of a study which would assess this. We can have a lot of retrospective data where because most of the evidence comes like, okay, the patient had higher concentration and he landed up in adverse event, or lower concentration he ended up having GVHD or anything, or a graft rejection. I am not sure whether I have an answer for your question.
No, thank you. Let's take this offline as a conversation, but I don't want to hold up the other conversation.
Thank you for that question, though. Hello, Dr. Sumit?
Hi, ma'am.
Yeah. Anything you would like to add? Dhaneria sir, would you like to add anything? Okay, so Dr. Sumit?
I will address this issue regarding the study in my talk.
So if you permit 5 minutes, can we quickly, my student actually dealt with this case, and if you permit, can we quickly do this case presentation of a patient where we used TDM plus pharmacogenomics to quickly 5 minutes. Kumarvel, can you please come up and present this? The cursor is not visible.
না ঠিক আছে আমি বলছি আমি ওদের লোককে বললাম যে 7 থেকে this one না now you have to share.
Thank you, ma'am, for giving this opportunity. So, as a part of routine clinical services like TDM services, so we come across this case.
It will be
Yeah. So here I will be presenting a case like 16-year-old female KR who was diagnosed as chronic kidney disease stage 5. So with the primary cause of congenital anomaly of urinary tract and kidney. So undergone living later renal transplant, that is allograft. The donor was father. The induction regimen we have used is ATG 50 and also tacrolimus was started as 6 milligram per day. So here you can see the post-operative days and tacrolimus dose and whole blood tacrolimus concentration. Even though we are giving adequate dose like 6 milligram BD, but we are not achieving the therapeutic range. So this, what is the clinical issue is initial post-operative period, the tacrolimus therapeutic window was not achieved despite giving high dose. So we planned a pharmacogenetic and pharmacokinetic analysis. The pharmacokinetic analysis is dose exposure response. So we have analyzed. So for this we have taken a written informed consent from the patient. So we did some special investigations like genotyping. For genotyping, initially we did like genomic extraction, that is DNA extraction by using the kit, and then genotype came as COP3A5 star 1 mutation, that is homozygous pattern. So here you can see that is SNP COP3 star 1. So see here you can see this we did like to explore the dose exposure response or analysis. So C0, C1.5 and C6. So the dose which was given here, it is 7.5 milligram BD in the POD of 65 days. Coming to below panel, here it is, we have given 4.25 milligram, like almost same dose, but it given us TDS, that is thrice a day. Why we have did like this? So in C1.5 we have high therapeutic range like this 37.88, but in C whenever we are giving 4.25 thrice a day, we have 25. So the thing is, these results suggest that the peak concentration achieved here, it is toxic range, and also the concentration at 6 is also high. So the suggested, we have planned for a scale dosing reduction, that is from 7.5 milligram BD to 4.25 milligram TD. The lessons learned we have from these cases, individualized dosing by using by doing the genotyping, and also the based upon the PK profile, so we have given TAD dosing. So this will possibly reduce the long-term CNA toxicity and also will improve the better clinical outcome and the graft outcome. Thank you.
Thank you, Kumar. Actually, Kumar actually did a lot of work in this patient's dose optimization. So I would just he just missed a little bit. So look at the peak there. That is when we were prescribing 8 mg BD. So 37.88. It's 37.88, which is way high. When we know that beyond 20 it is going to be nephrotoxic. So we could by TDS dosing we could bring it down to 25, and that actually increases the pill burden on the patient. But somehow increased pill with a better long-term outcome. So all I wanted to highlight is regimen optimization, keeping in view your long-term goals. Thank you. Yeah, Dr. Sumit.
Thanks.
Yeah, please.
Thanks a lot, Dr. Smita, and your place. I will thank you at the end, all of you. Maybe I will start my presentation soon. Thanks a lot anyway for inviting me, and all the previous speakers, Dr. Sandhya and Dr. Smita, has actually gave a good overview about TDM, so that I don't have to spend time talking about that TDM, how it is important for the patients. Here, my major area of work in the department is antimicrobial agents, TDM of antimicrobial agents. I can give you evidences on how it helped patients. What are the possible study mechanisms where you can actually prove that TDM works, etc. So to start with, sepsis. Sepsis is a threat to life, especially for particularly patients. And it's common in ICU patients, around 40% of them develop sepsis. And this 30-day mortality rates are as high as 37%. And with this outset, I would like to ask this question: why TDM of antimicrobial agents? Why is it important? Recently, an article is published in 2022 in Clinical Infectious Diseases. This is a meta-analysis done by Rekha Pai Mangalore and team. So, only the important things I'm highlighting here. TDM guided dosing was associated with improved clinical cure, improved microbiological cure, less treatment failure, and improved target attainment. So there are loads and loads of evidence supporting TDM of antimicrobial agents in critical ill patients. There are many. This is the recent one. So why this TDM should be integrated into hospital antibiotic policies? One important reason is the concentration effect relationship is well established for most of the antibiotics, especially all beta-lactams, aminoglycosides, vancomycin glycopeptides, and even to a certain extent polymyxin antibiotics. And you also know that some of these antibiotics are extremely toxic. Okay, and the duration of action of these antibiotics are relatively short. And the patients are presenting in acute conditions, and a lot of disease factors can modify the antibiotic dose required. For example, sepsis. It can cause capillary leak syndrome. So therefore, the antibiotic can go from the central compartment to the peripheral compartment. So the central compartment concentration will fall, or there can be third space fluid volume loss, for example, ascites, and we are treating a patient with lung infection. So when you remove the ascitic fluid, you're losing antibiotic. Then patients with renal failure, you need dose adjustment. Then treatment interventions can modify the antibiotic exposure. For example, dialysis in between, or the way you give an antibiotic, that can change the exposure of antibiotic. Then also there is good evidence available for relating the bacterial kill with the antibiotic exposure in the blood, or even in the CSF or other fluids. So there is a need for loading dose of antibiotics, at least for some of them, which have long half-life. So the Surviving Sepsis Campaign guideline recommends administration of effective IV antimicrobials within the first hour of recognition of septic shock and severe sepsis without septic shock. So this is very crucial. Effective antibiotics within the first hour of recognition of septic shock. So time is very crucial when you treat a patient with sepsis. And simulation studies, however, shows that the target concentration will not be reached at first dose for majority of critically ill patients, even if you use the most commonly recommended dose. Can you close the door? Even if you use the most commonly recommended doses. So, what are the factors affecting clinical outcome? Infection, where the infection is. Lung infection is the dose of antibiotic you need to treat lung infection same as dose required to treat osteomyelitis, or if the dose required to treat CNS infection? That is a question. Then second is the virulence of pathogen. Can you give the same dose of antibiotic for treating Klebsiella versus E. coli? Adequate source of control of infection. That is very important, especially when the patient is having pus in different body parts. You have to drain the pus. Without draining pus, even if you actually give a proper dose optimized antibiotic treatment, it is going to not help the patient much. Then pharmacological properties of antimicrobial agent. What antibiotic is? So you may have the sensitivity report, culture sensitivity report with you, and now the patient is having a skin infection. So this is skin infection. You need an antibiotic which is highly lipophilic. So even though you have the culture sensitivity report, you have to choose an antibiotic which is more penetrating to tissues if you have options to treat skin infection. So you have that choice and dosing of antimicrobial agents may be very important for deciding the treatment outcome. And also the patient characteristics, something like critically ill patient, they are very different from a normal patient admitted in ward, or whether there are significant comorbidities, extremes of body size, extremes of age. All these are factors which can contribute to change in drug exposure in patient's body. In 2021, okay, that's the latest, Surviving Sepsis Campaign Guidelines. They recommend the dose optimization of antimicrobials based on PK/PD principles. So there are a lot of factors which can affect the plasma concentration of drug. So you can't treat a patient with one dose of drug. You have to use guidelines, and when possible, you have to use TDM in routine practice. So, for example, I will give one example on colistin. We are doing this study, it's still going on. At the point when we recruited 61 patients for this exposure to determine the exposure to colistin in critically ill patients. Remember, all these patients received same dose of loading dose, 9 million international units of cholesterol sodium, all these patients received. And they were on 3 million international units of colistin as TID as a maintenance dose. So their doses are same, especially because this study was done sometime back 2019. People were not aware of how to adjust the dose of colistin, etc. So all the patients received almost similar dose of colistin. Okay, but see the difference in. So I will explain. This is one patient exposure in one interdose interval. This is another patient exposure in another interdose interval. You see the y-axis, how much it is spread, and the red line is the concentration that patient should have for optimal response. That means minimal toxicity. You know, colistin is toxic. It is nephrotoxic. It is neurotoxic. It can cause muscle paralysis. So to have optimal response, you have to have a concentration of colistin around this 2 milligram per liter steady state concentration. But see all these patients receive same dose, and see the spread of exposure between patients. So some patients are going to have so high levels, some patients are going to have so low levels. And this is the time when we were not doing TDM. We are actually doing the study, seeing the exposure. And we actually looked at the GFR relation. So normally colistin, the only guideline is dose it based on the creatinine clearance. Okay. Now, when you look at the GFR and the 24-hour AUC exposure of colistin, the higher the GFR, lower is the exposure, but the correlation is very, very poor. R square is only 0.14. What you need an R square is like more than 0.8. to say that, okay, that you use for dose adjustment guideline. Now, GFR you cannot use as a dose adjustment guideline because there is no correlation between GFR and exposure to colistin. So we have done some study. So we were doing colistin exposure monitoring before actually TDM was implemented, and after TDM, when we started implementing, we did a study on AKI. You see, before TDM was implemented, AKI was 32 acute kidney injury. Acute kidney injury while the patient is on colistin. By day 7, 32% of patient developed AKI. While with introduction of TDM and with dose adjustment, it reduced to 7%. Now, next is we couldn't do once clinicians get to know that, okay, this is so important in patient outcome, they will not be willing to do a randomized control trial. But it will be very difficult to do a randomized control trial. One is you cannot blind the patients, blind the study investigators or the patient. It's very difficult if you're doing TDM. So we have done this way. Like in those, we looked at patients who achieved the target concentration of colistin and those who did not achieve target concentration of colistin. And we followed them up for a period of 7 days. And we saw that the clinical improvement happened in only 44% of patients when the target was not achieved, while clinical improvement happened in 92% of patients when the targets were achieved. This is the same case for meropenem also, where for those patients who achieved the target, the clinical improvement was 93% compared to only 25% when the targets were not achieved. So this is unpublished. We are in the process of publishing this data. Now, another case of voriconazole. A 62-year-old diabetic diagnosed with left renal abscess underwent simple nephrectomy. And voriconazole was started on 3rd December. Okay, so on 3rd December, voriconazole was started. On 10th December, the dose of voriconazole was 200 milligram morning and evening, and the concentration was adequate, 5.95. But that is on the higher side. 5.95 is crossing 5.5. So therefore, the doctors have reduced the doses a little bit to 200 and 100. But over this period of time, the patient had improvement in the CRP. The inflammatory condition or the inflammatory process in the body generally improved. So inflammation subsided. So with this 200 and 100, the levels dropped to like 0.28, very, very low. So the doctors again increased the dose to 200 BD, and the level still it was less than 1. Okay. And then they had to increase the dose to 300 and 200 to reach a level of 1.46. Why this happened? Because inflammation, in the presence of inflammation, CYP enzymes are inhibited. Voriconazole is metabolized by CYP enzymes. So when there is an inhibition of metabolism because of inflammation, voriconazole levels will be higher. So the initial stages of infection, the voriconazole levels will be high, but as the inflammation subsides, the voriconazole levels drop because CYP enzymes take over and metabolize voriconazole. So even there was a study which proved the same thing. So you can't start a patient on a particular dose, especially with anti-infectives. You can't start on a particular dose and just leave the patient with that. You have to do follow-up and you have to do measurements. But there are some practical issues with TDM. One is there is a delay in achieving steady state. So normally we say for anti-epileptic drugs or for immunosuppressants, we wait for steady state in some cases. But many of these antibiotics have long half-life, and monitoring waiting for monitoring to reach steady state is very detrimental, because surviving sepsis campaign, they actually said if you don't monitor early, it is equivalent to not monitoring at all. Okay, you have to hit the target concentrations as early as possible. So especially in patients with renal failure, the half-life of drugs increase. So that is kind of difficult to understand when to monitor, etc., etc. And there is fluctuation in clearance and volume of distribution of drug over a period of time during patient's admission in hospital. So even though on day 3 the antibiotic levels were okay, on day 5 the antibiotic levels may not be okay. So the issue is here you need to do monitoring very frequently as possible. Okay. So first of all, there is a delay in achieving steady state. We can't wait till the steady state is achieved to do monitoring for dose adjustment. And another example I would like to talk about is vancomycin. Here, a 55-year-old diabetic diagnosed with left parasinusitis and normal renal function. Functional endoscopic sinus surgery was performed on 23rd May and drained pus, and CRP was only 10.4 on 24th May. And pus culture grown MRSA, and the patient did not respond to linezolid. So therefore, they changed the antibiotic to vancomycin 1 gram BD. That is a normal dose to start with. It was started on 29th May. And on 1st of June, we measured the antibiotic level. It was, the trough is only 5.72. That is very low. What we expect is something above 10 to be adequate exposure. So on 4th June, the doctors increased the dose, and by 4th June, we measured it again, but still it was only 6.85. On 7th June, we changed the dose to 1.5 gram BD, and on 13th June, we measured again, it was 14.1, which is adequate exposure. So this patient improved with a change in antibiotic dose. So normal dose given for vancomycin is 1 gram BD, but see this patient, and it's very common now, we regularly monitor vancomycin for most of our patients, even ward patients, and we see this pattern. For many patients, they need a higher dose. And after some time, as patient improves, maybe after 1 week or 2 weeks, if the patient is still on vancomycin, then they may need a dose reduction. So TDM really helps in patient improvement, especially if we do at the earliest. So now there are studies saying you don't look at trough, you have to look at AUCs. So, and there are even meta-analysis supporting vancomycin AUC guided dose adjustment to reduce nephrotoxicity. So there are plenty of studies to support TDM and especially AUC guided dose adjustments. So vancomycin AUC, especially in critically ill setting, we can't do because we are talking about 8 to 10 samples, and that too for ICU patients. It's impossible. So how can we overcome this situation? So what we do here is we use PKPD model. So the typical way we actually do is we get the treatment history of vancomycin. We are not the exact date and time, when was antibiotic started, what are the times at which this vancomycin was given, what was the dose at which dose that we were given. Next, all this detailed drug history we will take. We actually do not go to ICU for this purpose. We have people in the ICU who gives us this information to us. So to reduce the manpower going inside the ICU, we did that. So so the information come to us, and we advise on at what time we have to take samples, and it doesn't have to be trough. So we advise maybe 1 sample or maybe 2 samples or maybe 3 samples to take, and we use this information. We put all this information in a software called Best Dose. There are other softwares which are available, but this is the cheapest that we have. We plan the treatment, and then the software will come up with the dose suggestion. Okay, so you can see that the points in red, these are the time points at which we have actually measured. We have taken the sample and measured vancomycin concentration, but the software is able to give the full past history, how the exposure was, vancomycin exposure was over the past many days. So it's not just one AUC that we're talking about. We are seeing the entire AUC of the past few days and how the AUC will be in the future, provided the serum creatinine continues like this, or provided the body weight of the patient continues like this, what is going to be the exposure and what is the actual dose that we have to give. All that the dosing software can tell us, but we have to use our sense, and based on that, we have to suggest the dose to the physician, because physician at times won't be able to take a decision on dose. So normally what we do is we pharmacologists do dose suggestion. Okay. So we look at the model quality. If the model quality is good, we also report the predicted 24-hour AUC and we recommend the dose. So patient's creatinine is going up. Patient creatinine going up maybe because of sepsis. It may not be because of the antibiotic levels being high. So then I'm just giving you an example. So then we actually, when we tell the, okay, doctor, you increase the dose of vancomycin, they will be actually, okay, kind of, oh, should we really? Yes, we have to give them confidence. You please go ahead and increase the dose of antibiotic. And actually, by doing so, the creatinine falls down. Okay, so yeah, so what is the way forward? I told you antibiotics, the best way to monitor TDM is to monitor as frequently as possible. Now for ICU patients, things like microsampling devices or biosensors can actually continuously monitor the antibiotic concentration, especially in the initial few days when the patient is not really doing well. So those points you can use biosensors. Now biosensor is not available in India. There are places where biosensors are in research. So, but what we can do is we can at least do the TDM and we can use the concentration estimations in the Bayesian models, PKPD models. PKPD models we have to develop in our institution, or we can use the ones which are available outside, but we have to validate those models in our patient population. So what are the advantages of Bayesian models? We don't have to wait for steady state. Vancomycin, once we start giving to a patient, we don't have to wait for 96 hours, especially if the patient is having renal failure. We don't have to wait for 1 week to see, okay, whether their levels are adequate or not. Use the Bayesian models. You can do measurement even in the first day and suggest the dose in the first day itself. You can sample at any point in time. So that makes your life more comfortable. You need AUC with you can find out the AUC with very few time points. And the most important question is when to do TDM of anti-infective agents. So this is a publication which I have done in Journal of Clinical Pharmacology. So I have published a model for colistin based on the study. So this is a very simple model. Normally colistin is given as cholestyramine sodium. So all the models currently available are, you have to measure for both cholestyramine sodium and colistin to use their models. But in my case, in this particular model, this is a simplified model where you can just use colistin concentrations to predict the colistin exposure. You don't need to measure cholestyramine sodium. Actually, measuring cholestyramine sodium is a very tedious procedure. Okay, so in this study, I found that there was a subpopulation of 22 patients whom we had actually followed up for 7 days. And in that, if you look at, you see the how the even though, so remember cholestyramine sodium, we give a loading dose, 9 million units loading dose that we give actually, but still it took 96 hours, the concentration slowly raised up, okay? It took 96 hours for the cholesterol concentration to reach steady state. So should we just wait for 96 hours? No, we should not. So as early as possible, monitor. So this is another journal another article which was published in Antimicrobial Resistance and Chemotherapy, which states that delay in measuring beta-lactam concentration was associated with clinical failure, longer ICU stay, and higher mortality. Okay, so time is very crucial. You have to monitor as early as possible. So now we have established precision dosing for our ICU patient. We have started only in one ICU, SICU. We have over 200 beds, ICU beds. But it's impossible to start with all the 200 beds. Now we have started only for 20 patients. We need manpower to do this. So how we are doing this, I will let you know. Precision dosing for antibiotics. So how we initiate TDM. So an ICU technical assistant from the ICU, he will give information on which all patients are on which all antibiotics. We see that. With the TDM consultant will look at it and they identify the patients who need TDM. For example, some patient may be just in the ICU, just on an antibiotic, completely empirically treated, no fear, nothing else, then we don't have to do TDM, something like that. So identify the patients who need TDM and they inform to the antibiotic TDM lead. Currently in our hospital, I am the antibiotic TDM lead. And then we contact the ICU registrar. Okay, so we have decided this patient needs TDM. And the advantage of doing this is there is no delay. So as soon as the antibiotic is started, at least within 24 to 48 hours, this information will be given to the antibiotic TDM lead. and the TDM things will start. So the ICU registrar, we will inform the ICU registrar. He will he will manage the appropriate timed blood collection, and that usually happens within 48 hours of starting the antibiotic in the ICU. And then he will take part in dose optimization discussions with the anti-infective TDM lead and TDM consultants. So finally, the ICU consultant will decide on the dose optimization. So we will give the dose suggestions. Okay, so this patient needs 10 lakh units of polymyxin BD or 15 lakh units of polymyxin BD. We suggest, and the ICU consultant take the final decision on that. Maybe in association with consultation with ID physician, maybe. So now, once you change the dose, it is the responsibility of the TDM team to continue following up that patient till the patient is stopped on antibiotic. That particular antibiotic should be, we have to monitor continuously till the antibiotic is stopped. Because now you might have suggested a very high dose or a very low dose than the physician normally gives. So you have to take the responsibility to continuously follow up that patient. So that is run by the TDM consultant till the patient leaves the ICU. Faster than culture. Okay, so so for example, if the physician decided to start a patient on meropenem, we do meropenem, we give the reports within 48 hours. But by the time the culture reports come, it will be like 48 or even 72 hours. And plus another 2 or 3 days, 2 days for getting the MIC reports. But by then, the clinician will know whether the antibiotic concentrations is sufficient to kill and all the meropenem susceptible organism, because we are doing TDM within 48 hours. And if the patient is not responding to meropenem, they can just go up on to a higher antibiotic, or they can go to adding another antibiotic. So you can actually save a precious time. So you don't have to wait for all this culture and MIC and all that stuff. But you can facilitate when in the precision dosing, a clinical microbiologist can be involved so that they can do the MIC as soon as possible. And we repeat measurements, we look at the clinical status of the patient, and we do dose optimization. So for each of these patients, minimum we spend around 15 minutes. I mean, the pharmacologist, along with the PharmD, we spend around 15 minutes. So we need a huge workforce for doing all this. So pharmacologists are not enough. We need PharmDs to do all the groundwork also. So we do dose optimization till the patient leaves the ICU. So in the summary, TDM of antimicrobial agents will improve target concentration achievement, clinical outcome, reduce the length of hospital stay, and reduce the risk of toxicity. And TDM gives objective goals. You have numbers. So if the numbers are not attained, if the concentrations are not attained, you are working on those. You have objective goals. Increase the dose to that. So if the levels are low, even synergism will not work. You can't just add another antibiotic and imagine that will work. No. If the concentration of antibiotic is low, even synergism will not work. Okay, so you have objectives for antibiotic treatment, and this guides selection of antibiotic appropriate for patient management. Use of PK models for dose optimization assist with selection of appropriate dose to achieve target concentration. For effective implementation of TDM, a team is very important. Team approach by including a pharmacologist, a microbiologist for dose optimization of degraded patients is suggested. And don't forget, early TDM improves patient clinical outcome. All measurements should be implemented to achieve sufficient, all measures should be implemented to achieve sufficient antibiotic concentration at the earliest in the course of anti-infective therapy. Thank you, the organizing team. Especially, I would like to thank I would like to thank all the organizing committee, Santanu sir, Dr. Smita. I am extremely happy with Dr. Smita because she is very active in spreading TDM across India. She is a member of ITDM City, and she is standing as a ITDM City. In which committee? I'm sorry.
I'm in the immunosuppressant committee and the pharmacology committee.
you're now standing for counselor,
Yeah,
ITD
this is
city councillor.
yeah. This is the election. Sorry, I
Yes.
forgot.
Yeah, election.
I
So
actually thought about the committees, but this is the council election. I forgot.
yeah, council. So please, all those who are in the ITDM city, please vote for Smita ma'am. She is actually very active in promoting TDM across India. Thank you. Thank you all.
Thank
Any
you, Dr.
doubts?
Sumit. 89, sir.
Okay.
In the
Any
paper
question?
it was written as 88.
Okay. So that
And
I got
shall I
from
stop
one of
share?
the internet pages.
Yeah.
Yeah. So anyone has a question?
I have a couple of.
Sure, sir. Please go ahead.
One
Sumit.
is about beta-lactams, the need for having TDM for beta-lactam antibiotics, because as we know, it has a very wide therapeutic margin. This is one. Second is, you have shown in one slide about vancomycin, TDM. Can you go to that slide by any chance? Because what I find that the treatment was started in, I think, 3rd week of May, and then the final suggestive this thing, if you look at this data, that 24th May and then 13th June, so it's quite a long time, that by gradual this thing you could optimize the dose through the TDM service. So how the clinicians responded to this, or whether this model actually adding any value?
Hello, Dr. Smita. I was not able to hear at all.
Okay.
Something I heard partially. Can you please?
Can I repeat the question for you?
Yeah.
Yeah.
Yes.
So, Dr. Tripathi wants to know, looking at the data that is on the slide, that on 24th of May you kind of got information about the patient, and on the 1st June you started doing the TDM, and on 13th June we find that the patient is possibly responding. So
Sure. Yes.
yeah, so so now the patient is a big window. That's what Dr. Tripathi is pointing out to. 24th May to 13th June.
Yeah, that's the sad part about the story. So actually, they were treating the patient with linezolid for quite a long time, and then started vancomycin. As doctors pointed out, that also was continued for a long time. And initially in the wards, unfortunately, we are not able to do precision dosing in the wards because it's a huge hospital, around more than 2,500 beds. So we are right now focusing only in ICU patients. Only when the request comes from the ward, we are able to know, okay, understand that, okay, this patient is getting a vancomycin. That's a sad part, that we are not able to implement precision dosing in the wards. But ICU, yes. ICU patients are more sick, and yes.
And
definitely it would have been better if we actually came to know about this patient early and dose adjust early. And at that point, we were actually not using models. We were using tough concentrations. We are talking about 2019, and we were not giving any dose suggestions. So they themselves were increasing the dose. So they were not very confident on increasing the dose. So all that matters. Now, with the use of PKPD models, we are able to give dose suggestions, and that makes everything faster. But again, the problem is wards, we are not able to cover, only ICU. And that to only one ICU, we don't have enough manpower to do this.
the dose adjustment also, I find that 1st June, then 4th June, the dose has been adjusted. So it's more than, I think, 72 hours or more than that. And then again, 4th to 7th, again, dose has been adjusted. So how much of this was the turnaround time, and how much time they took, the clinician, to actually readjust the dose based on your TDM service?
Sorry, Smita ma'am, can you?
So essentially, sir is asking from 1st June, 1st June was the first vancomycin concentration done, and then the second dose adjustment was done on 4th June, then 7th and 13th. So about 3 to 4 days gap in between each.
Yeah.
So how much
Yes.
is the time that was taken? I mean, to my mind, these are very good intervals. I mean, if you can really change the dose in this, but how much was the time that the lab took? How much was the time the TDM
Okay.
consultant took to? I mean,
Mhm.
this is simply a self-assessment
Yeah.
that how efficiently we can do the service, and how much was the time taken to convince the ICU physician to do the dose adjustment. So what was the most difficult part which took, I mean, you 3 days to 4 days during each interval?
And Dr. Smita, just to add to that, meanwhile, because it's a critically ill patient, the patient's condition is also changing probably. And by the time you decide about it, whether the vancomycin trough concentration keeps its relevance, because in 3 days, a critically ill patient can also have worsening or improvement, whatever.
Yeah, so Dr. Sumit, over to you.
Okay, so the question that you asked, time that we take. So around 24 hours we take for giving the report. That is the lab delay. That is even for precision dosing, that 24 hours delay is still there. Now, at those time points, we had to wait for trough to go up because we have changed the dose and we were not using any PKPD models. So therefore, it took around 3 days. So, okay, so we said wait for 3 days and third day you send the sample to us. So that also added that point because we were not using PKPD models. The best thing is go for biosensors. Biosensors has not reached India, but it will substantially reduce the time of hospital stay for the patient. And of course, 1 day in ICU costs nothing less than 10,000. So if whatever cost you are saying, the cost of TDM you are saying, it is nothing compared to the length. If you can reduce the hospital stay, that's the best thing that you can do for the patient economically. I hope I answered that question. I was not able to hear properly.
No, absolutely perfect, Dr. Sumit. I would like to add one thing. That is, when you are putting it into the Bayesian, the dose adjustment software, that also takes a bit of time to compute and do the model and then make a dose suggestion. If if I know best dose,
No.
it doesn't
No,
take
no.
time.
So as soon as we receive a sample, we get the proper history. So the sample will be going for processing. It may within if it's coming in the morning, we will do processing everything in 8 hours time. But meanwhile, we get all the full dose history for the patient, and that is the time-consuming part. So sample has gone for analysis. You may take around 10 to 15 minutes for entering all the details from the ICU into the BestDose software. And then we just have to wait for the sample concentration to be ready. We enter the concentration immediately. Pharmacologists have to see, when we have to use our wisdom before suggesting any dose. It's not like computer will tell you some dose and you just have to tell that. No, we have to look at the patient's condition, and there will be multiple. So for example, one example I will tell you: CNS meningitis. Patient is having MRSA meningitis. We just don't suggest like okay, if the levels are only 5, trough is 5, something like that. We just don't suggest, okay, just increase the dose to 1.5 grams. That may be the thing that the computer may be telling, but then we have to use the literature also. So therefore, literature says CNS meningitis, give the dose as continuous infusion. So then we have to go say that, okay, you may have to give vancomycin as 2 gram, a higher dose as a continuous infusion. This will prevent the toxicity, nephrotoxicity, because you don't have Cmaxes. And it will also improve the penetration of antibiotic into the brain. So that's the importance of a pharmacologist here. We have to use our MBBS knowledge and also pharmacology knowledge to actually dose optimize. They help the physician decide the appropriate dose. Okay, so yeah, that's a big role that we play. We have to have confidence for that. Yeah, yes, it's a big role. Yeah.
Yeah, thank you so much, Dr.
But
Sumit.
that part will take some time. Okay, deciding on the dose maybe take it may take around 10 to 15 minutes. That's it.
Right. And we all who work in labs, we understand that in fact in the lab manpower is always at stake, and people doing multitasking in institutes and turnaround time is really an issue. And if you could do it in 24 hours, I would really appreciate your team. That's
Yeah.
a good job.
Yeah, but that is not enough for antibiotics. Yeah, but that is something.
Yeah, I
Something for
understand.
the
I
patient.
understand. Everybody would be happy with a point of care kind of a thing, and
Yes.
yeah, we have to reach there someday. So Dr. Manjunath from Actrek has a question for you, Dr. Sumit.
Yes.
Hi, Dr. Sumit. It's like a wonderful presentation and a great work
Uh,
from you.
I'm not able to hear. Can you give the mic to? I'm not able to hear.
Yeah, we'll try to.
Hi, can you hear me?
Are you able to hear him now?
You can continue, or she will again.
Sorry.
Yeah, can you hear
Okay,
me?
you can.
Right. So it's a great work by you and great contribution for the TDM. So a couple of questions from me. So for the colistin, as of now, majority of the literature shows like the free concentration of AUC by MIC ratio has to be a specific range, like 24.5 to 49 something. So now many people are like as employing different ranges, or the AUC ratio, or the Cmax ratio, or the trough concentration. Some are saying like the steady state concentration, right? So you have taken a steady state concentration of 2 milligram per liter. So we also have undertaken a similar study where we have kept a cutoff of 2 milligram per liter. We have undertaken the study in the bone marrow transplant patients. So is there any validated result or information about using the steady state concentration of 2 milligram per liter?
You can.
Okay, so Dr. Sumit,
What drug?
should I re-articulate, or you would be able to? Huh?
What drug? Yeah.
So Dr. Manjunath's question is, for colistin in a critically ill patient, we have two biomarkers: C0 versus C0 at steady state versus AUC upon C0. That's what some other group is investigating. And AUC upon C0, that ratio people have seen from 20. AUC by MIC ratio is up to 49 point something, is some group is suggesting and working on. Dr. Manjunath has also started working in that area in bone marrow transplant patient. His question specifically is, AUC is, C0 steady state 2 milligram per deciliter is a recommended standard. Where does this number come from?
Oh, okay. All right. Thank you. Thanks for the question. Now, colistin is an antibiotic which has very poor penetration to deep tissues. Especially if the patient is having a lung infection, you may have to add some other antibiotic along with it. So because of this exact reason, colistin penetration is very poor. Normally, we talk about colistin when the patient is having bacteremia, or the patient is having urinary tract infection. So the number more than 2 to 2.5 steady state concentration. So which means AUC divided by the interdose interval will give you steady state concentration. It's not just C0, the entire AUC divided by the interdose interval, that will give you the steady state concentration. So it should be between 2 to 2.5. And the normal cutoff for MIC to say that the organism is resistant for colistin is 2. So if the organism having an MIC of, if you want to cover an organism with an MIC of 2, we have to have antibiotic concentration at least 2. Okay, that is a concept. That's why the concept of 2. And it was proved in many in vitro studies that if, for example, mice thigh infection model and all, if you achieve an average concentration of 2 to 2.5 over a period of time, that is able to cover an organism with an MIC up to 2. So anything less than 2, you can treat. The problem is you should not treat an organism which has an MIC of more than 2 because beyond that concentrations, cholesterol will cause toxicity. So you can change this average steady state concentration to AUC. AUC is a better way always to work with. Now with the model that we have made, the AUC, we can actually see AUC with 1 or 2 concentrations. So 24 AUC for cholesterol, we should target something like 50, not AUC by MIC, AUC I'm telling. If the AUC is more than 50 or if it is something like 100, it will cause nephrotoxicity and neurotoxicity. And also we have to take into consideration the duration of therapy. For example, if the cholesterol is given for 20 days, you can't say that, okay, the AUC of 75 is okay. 24-hour AUC of 75 is not okay in that case. It can cause toxicity. So you have to also consider the cumulative accumulation of cholesterol on the patient's body. So if we target an AUC of 50, that means if you convert it into steady state concentration between 2 to 2.3. If we are able to achieve this, any time in the 7-day period, that will be adequate to treat a patient with a MIC, with an organism with an MIC less than 2. And for bacteremia, UTI, and intra-abdominal infections. But if it is a lung infection, you have to add some other antibiotic along with cholesterol because cholesterol cannot penetrate into lungs. Am I clear? So the therapeutic ranges are like that for cholesterol. Am I clear?
Right. We also did the
And we don't look at MIC. The problem is because cholesterol penetration into tissues are very poor. So what we are aiming for is at the earliest reach the highest possible, which will not cause toxicity. So the highest you can go for is 50 AUC or 50 milligram hour per liter. So hit that concentration and continue hitting that concentration till the patient recovers. So we don't no point actually looking at MIC also because then you decrease the dose, the antibiotic may not be penetrating into the tissue. All that can cause issues.
So when you're
Even though
hitting
people normally say AUC by MIC of 50 is good, but it's not. I will not suggest that for an ICU patient. ICU is hit the maximum, which is less top.
So we did a similar study in the bone marrow transplant patients. Okay. So wherein we try to identify which is a regimen that is suitable for the patients. Okay. So like the cholesterol label says like to give the drug at 25,000 international units per kg body weight. Okay. In that 3 times doses. So if you look at that one, the 3 million units will not touch it. 9 million units. So we did the pop PK. We did the PK initially for the first dose as well as the steady state. And we have simulated, we did the PK/PD modeling and we came out with the result that you have to give a loading dose as you are suggesting with the 9 million units followed by the 4.5 BD or 3 times thrice in a day. And wherein we found like both these regimens are achieving a good concentrations of 2 milligram per liter, the steady state one. But the 4 million units BD1 is crossing the trough concentration of 3.3 milligram per liter, which is toxic. So what we have suggested to the clinicians is to start with the 9 and followed by 3 million units 3 times a day. So this is what like our study has resulted in that.
What I understood is you have done simulation to reach a particular concentration, right? To reach a particular AUC. Is that correct?
So his point is to aim to attain 2 milligram per deciliter steady state concentration.
Okay.
You have 2 options. Your loading is 9 million. First, your loading is 9 million units per. That's the loading. Then you have 2 options: either to adopt a BD dose of 4.5 million each, vis-a-vis a model or 3 thrice daily dosing, which is 3 million units. So their point is when we dosed the patient 3 times a day, our attainment of the steady state trough concentration was better, whereas with the BD doses, they attain a concentration somewhere around 3.2, which was toxic.
Okay. Yeah. Sure. Okay. So for colistin, there is no evidence available to say that if you reduce the frequency, total dose giving the same, but reduce the frequency will cause toxicity. There is no evidence available for that.
Yeah.
As far as I know, there is no evidence available for that.
So this is their new study. I mean, this is their study where they have found this. Okay.
Okay.
So there's one more question from Momita who asks about the TDM of voriconazole. So there are ample guidances, Momita. I am ignoring your question. I would send you the reference and with Dr. Sumit in the loop. Okay.
Okay, ma'am. Yeah.
We'll proceed for Dr. Tripathi's talk and then we will conclude the session. Okay. Thank you, Dr. Sumit.
Thanks a lot.
Thank you.
Thanks a lot. Thanks a lot for having me. Thank you.
Thank you for sparing your time.